So with that, I'll hand it over to our next speaker, Dr. Srikumaran, who is an academic shoulder surgeon at Johns Hopkins, and he's done a lot of basic science and clinical research on transosseous techniques. So, Uma, if you want to take it.
All right, perfect. Thanks, Brett, and thanks for organizing this and inviting me to share our experience with this. It's a great opportunity to learn from others who have taken on this approach, and appreciate your efforts in this area. So I'm going to talk about this, as Brett mentioned, from a green perspective and what that means for all of us. So I don't have any disclosures related to transosseous technology. In fact, some of my disclosures are actually with anchor companies. So just take that as you listen to this talk. Our objectives, as Brett's already outlined, the evolution of rotator cuff repair. So we specifically look at this according to transosseous technology and comparing it to what's considered to be the gold standard in anchored approaches, which is that transosseous equivalent. And then spend a little bit of time on the biomechanical concepts, and I'll review our latest clinical outcomes. And I'll try to show it to you from a green perspective. So why should you care about this green approach? You know, maybe it's just that, you know, you hug trees. It's okay to be an environmentalist. That's great. It's a way to reduce, recycle or reuse things, and maybe you just don't like to waste, and that's always a nice approach. Or maybe you just hug money. Maybe the green is about the money that Brett's referencing to. But really, I think green is about value, and Dr. Matson speaks about this really well in regards to all kinds of different technologies in orthopedics, and I think transosseous fits the bill perfectly. As Brett mentioned, the evolution from both our approach perspective as well as the constructs that we use. Anchors were great to get us to a fully arthroscopic approach, and as that's evolved, the question really becomes, can we get back to an transosseous approach done fully arthroscopically? I mean, there haven't been any studies that have demonstrated that an arthroscopic technique is better than an open technique. So it's just really a patient-driven thing that they want the surgery performed arthroscopically. So can we do it in a fully transosseous manner? And how do we get there? So this is my preferred approach or technique. It's very similar to doing these rotator cuff repairs with anchors. You place a pilot hole in the same fashion, and then you can use an instrument. Instead of inserting the anchor, you can insert this hook device and connect it to a lateral tunnel. And you have a passing suture, which you can then apply any number of sutures to, or different types of sutures, tapes, for example, and complete your construct in a very similar fashion. So if taught this way, I think it is accessible to residents and fellows without a problem. And then, as Brett also referenced, this cerclage sort of compression of the rotator cuff is ideal in many ways. So let's review that from a biomechanical perspective. So some of the literature would suggest that a transosseous equivalent with the anchors, as you can see on the left, has extremely high failure loads, and which is why it's so popular. But even transosseous technologies can have extremely high failure loads, as well as low gap formation, and achieve larger footprints than we can expect from anchored points. As Brett was also mentioning, single anchor brings you down to one area. How can you spread that out? So a lot of the studies will suggest the transosseous equivalent has high type 2 failure rates, or muscle tendon junction failures, compared to transosseous approaches that have a much lower rate of muscle tendon junction failures. And if they do fail, they're going to be tendon from bone again, which is much easier to revise. So in this study that we performed with matched pairs, you can see the highest percentage of type 2 failures were in the transosseous equivalent or anchored approach compared to the tunnels. And that exists with other literature as well. Kim et al. In 2016, again, finding type 1 failures. But what about, type 2 failures mostly in the transosseous equivalent group. But what about tissue perfusion, the other side of this, that what you get with excessive compression may be sacrificing the perfusion of the tissue. And this was demonstrated in a rabbit study by Kim in 2017. So the initial conclusions from some of this biomechanics work would suggest that anchored TOE constructs do demonstrate higher failure loads than TO, but the transosseous constructs are quite high themselves, maybe not in absolute terms, but we're going to show you why this may not be correct. And then the failure mechanism is pretty well established, individual studies as well as large reviews. So how can we assess some of this work, and what other factors are associated with construct strength? So when we did a systematic review and a meta-regression of over 40 separate papers about the biomechanics, specifically of rotator cuff repair constructs, we identified some independent covariates. So suture type, number of sutures, number of suture limbs, the number of mattress stitches, and the number of anchors, and finally construct type. So is it a double row transosseous equivalent, a single row, or standard double row constructs. And then we looked at failure load and failure mode. And really what we find, it's really all about the suture. So the strongest predictors of repair strength relate to, one, the number of suture that are used, and actually the number of suture limbs that are passed through the actual tendon, as well as the type of suture. So dimensions of the suture, whether it's a wide bore or like a tape versus a cord type suture. So when you control for these factors for suture material, there's no difference in rotator cuff strength between any of the construct types. So single row, double row, TOE, or transosseous technique. So you can achieve any strength you want in terms of load failure based on your use of sutures and the fixation points that Brett mentioned. So the other findings again confirm that TOE repairs are associated with high type 2 failures, as referenced to either concentration of force along the medial row that might be too high. So when we consider this contact area and compression, which we're trying to achieve with any technique, the TOEs have shown favorable compression areas compared to other anchored approaches, but not compared to a transosseous approach. It does have the best contact area when you do a fully transosseous technique where all the pressure is down evenly across the cuff tendon into the tuberosity. But with compressive ability, that goes hand in hand with tying the medial row for anchors, and that leads to the type 2 failures that we're talking about. So the best balance really comes with respect to contact area and compression is with the transosseous repair. You can achieve this large contact area, a favorable compression pattern with high contact pressure, all things you need for high healing rates. So this you can get this compressive pattern without using that medial row compression and getting that stress riser, and therefore avoid that type 2 muscle tendon junction failure. So moving on to our clinical experience, this was recently published, our matched cohort of rotator cuff repairs in core. We basically looked at the gold standard in an anchored approach, which is the TOE, versus a fully anchorless transosseous technique, and compared both clinical as well as patient-reported outcomes with ultrasound follow-up. And we had a minimum 2 years of follow-up. So this was retrospective, but matched for sex, age, tear size, smoking status, all the important confounders for rotator cuff healing. And our primary outcome was the ASES score, and we powered it to detect the minimal clinical important difference of 12 points. And then the ultrasound was performed at 1 year separately by a blinded, the interpretations by a blinded radiologist as to the surgical technique. So as you'd expect, the results are equivalent, regardless of 1 year or 2 year follow-up. ASES score, the subjective shoulder value, were similar across groups, and pain scores also at 1 and 2 years were equivalent. The range of motion and functional outcomes were also similar, and the ultrasound evaluation was equivalent. When we broke it down by size, of course, that's the biggest predictor of your healing rates. This is equivalent across transosseous as well as transosseous equivalent approaches. So conclusions here are that both groups can achieve clinically meaningful outcomes. As Brett also mentioned, this is a bit of a surgical ceiling in rotator cuff repair. We have a lot of good techniques to get healing to happen and clinical outcomes to improve with respect to our PROs. There's no significant difference in procedure duration or re-tear rates and any clinical outcomes. Of course, this is still a retrospective review and a single institutional experience in terms of our limitations. But this was our first adequately powered study to detect the MCID for the ASES score with clinical outcomes beyond 2 years, which were equivalent re-tear rates, again, equivalent with equivalent resources in terms of operating room resources, but significant cost savings if you look at the implants themselves. So takeaway points are that the biomechanics can be can achieve similar strength, and it's really about the number of sutures and how you place them and the suture type as well. Clinically speaking, we can achieve equivalent outcomes. So if your costs are similar, this is a very simple cost minimization analysis. So your value is going to be much higher should your costs be lower and your outcomes are equivalent. So this represents much greater value. So can we go green? So speaking to the point of adoption, it's an additional tool, and it helps if you can teach it in a way that's very similar to anchors because they dominate the market. But it is also an opportunity to disrupt this market and really drive the cost of anchors down, and also further innovate in the transosseous space and make it easier and simpler for everyone to achieve these types of outcomes. We've talked about this surgical sealing and finding the most affordable way to allow us to shift more to the biologics, which are going to be expensive, especially initially. So this opens up that opportunity for even cost restrained or bundled environments to start looking at those things. So really being green is about less waste, especially plastic, all these disposable anchors, and each handle is thrown away, being less expensive in general, having a higher margin if you own your ASC or have any involvement with that, it's important. And finally, most importantly, you're achieving an equal or improved patient benefit. Thank you.
Uma, did you, I may have missed it, did you show any difference in the ASES scores of the anchor versus transosseous? It seems like the transosseous have very high ASES scores because of the pain, you know, slightly higher, it seems, than anchors. I don't know if you've noticed that or not.
So we only, not in this study, because we're looking at it at 1 year and 2 years. So by then everything kind of washes out. Everyone's going to be the same. I think if you measure it at 6 weeks and 3 months, in that time frame, you'll detect that pain benefit that a lot of folks have demonstrated or know anecdotally from their own experience, that the transosseous technology seems to have less pain. So that gets reflected in an ASCS score early. But at the end of the day, by a year, they're all the same.